para terminar, el doctor Hagop Kantarjian, quien es jefe del departamento de leucemias del MD Anderson, un hematólogo muy famoso que no necesita mayor introducción, nos va a hablar sobre las nuevas terapias para el tratamiento del LA, qué es lo que viene en el futuro. Bienvenido, doctor Kantarjian, gracias por estar aquí y lo escuchamos.
Thank you very much for the invitation. What I'd like to do in the next 20 minutes is show you the progress in research and treatment in 2023 with a particular focus on the research at MD Anderson. So on this slide, I show the results of the traditional intensive chemotherapy in childhood and adult ALL, using 15 chemotherapy drugs in intensive regimens, which are given over 3 years. In childhood ALL, we now can achieve potential cure rates of over 80%, as shown on the left slide. And when we apply the same traditional classical intensive chemotherapy regimens in adult ALL, we have seen that up till 2010, the blue curve, the 5-year survival has increased to about 50%. And we have added few things that improved the survival in the last decade, which I'll discuss. But even the red curve does not show the true revolution in adult ALL therapy with the addition of the targeted therapies and the new antibodies, as I'll show. The reason for the difference of about 30% in the cure rates between childhood and adult ALL using the same classical intensive chemotherapy regimens is due to the fact that there are 4 sub-entities in childhood and adult ALL, which have different incidences and prognosis. So we know that the patients with hyperdiploid karyotype and ETV6 ranks 1 constitute over half of childhood ALL, and they have a favorable prognosis, but they constitute less than 10% of adult ALL. In contrast, there are 2 entities which historically, with the classical intensive chemotherapy, have not done well: Philadelphia positive ALL and the recent Philadelphia-like ALL. These 2 constitute about half of adult ALL, 15% of childhood ALL, and with the classical intensive chemotherapy, they used to have an unfavorable prognosis, but not anymore, as I'll show you in the next slides. So what is wrong with continuing with the traditional intensive chemotherapy? What's wrong is we're using a lot of intensive chemotherapy in induction, consolidation, intensification, and maintenance over 3 years. So this could be manageable in leukemia centers of excellence and quote-unquote ivory towers. But when you apply it to the common practice in emerging nations, in community practice in the United States, among poorer populations, because of the socioeconomic reasons, the patients have a high dropout rate. And when they relapse, the cost of treatment quadruples. So it's very important that we do something about the frontline therapy to improve the prognosis. And with the intensive chemotherapy, there are multiple long-term complications that the cured patients have to face. So even when you look at large studies in advanced nations, such as Peru and India, when you look at childhood ALL, the 3-year survival is not 80 to 90%. It drops down to about 60 to 70%. And among patients who are even 10 and 20 years old, the cure rate goes down to 35% and much worse in patients over the age of 40. So the solution, in my view, is to try to get away from those traditional intensive chemotherapy regimens and try to use less intensive chemotherapy for shorter periods of time, to which we add the new effective therapies, such as the new BCR-ABL tyrosine kinase inhibitors in Philadelphia positive ALL, but most importantly, incorporating the newer antibodies, which are highly effective. For example, the CD19 bispecific T-cell engager blinatumomab and the CD22 antibody drug conjugate inotuzumab. So we also need to start measuring residual disease by next generation sequencing, or clonoSEQ, which looks at over 1 million cells rather than looking at MRD simply by flow cytometry. And at MD Anderson, we are already developing what we call the dose-dense mini-CVD in Oblina regimen, with or without CAR T cells at the end of therapy, depending on NGS MRD. And this is a treatment that will be completed in about 7 to 9 months. So I believe it is time to break with 50 years of traditions in adult and perhaps childhood ALL therapy. I will show you that in Philadelphia positive ALL, we have now a regimen without any chemotherapy and without transplantation, which gives us excellent results. Also in the pre-BALL, we are using less chemotherapy for shorter durations. We are already adding the antibodies targeting CD19, 20, and 22. And we started using the CAR T cells not in the setting of active relapse, but in the setting of complete remission for treatment of minimal residual disease, the same way as we do for allogeneic stem cell transplantation. In T-cell ALL, we are still stuck with the intensive chemotherapy, but we are starting to introduce venetoclax as well as possible CD7 CAR T cells, which may change the outcome in T-cell ALL. At MD Anderson, we developed the hyper-CVAD regimen in 1992. We changed the CNS prophylaxis to intrathecal therapy. And in 2000, we started adding rituximab to the hyper-CVAD in both Burkitt and pre-BALL, and we showed improvement of the results, which were confirmed in randomized studies. In Philadelphia positive ALL, we added the BCR-ABL kinase inhibitors in 2000, and we advanced them to the second and third generation TKIs. But really, the big breakthroughs have come recently in 2010 with the addition of the antibodies, blinatumomab and inotuzumab, and in 2017 with the shift in Philadelphia positive ALL from intensive chemotherapy transplant to non-chemotherapy regimens, which I'll show you in a second. So we at MD Anderson continue to use the hyper-CVAD regimen. We believe it is better than the pediatric inspired regimens. It is, of course, myelosuppressive, and for people who use it, we have made some changes. For example, in the even courses, we reduced the methotrexate by 25% and the Ara-C by 33%. But this is a review in cancer that gives you some hints as to some of the less common toxicities with hyper-CVAD that you can avoid, such as the renal toxicity with methotrexate, the cerebellar toxicity with Ara-C, the vincristine neurotoxicity, and the myelosuppression complications. So if you use the hyper-CVAD, please read this paper, which can help you improve on some of the side effects that you've been encountering. First, we're going to start with Philadelphia positive ALL, and this is where in 2002, still the results were very poor because at that point in time, the imatinib was not yet incorporated into these regimens. So with intensive chemotherapy, as you see on the slide, 90% of the patients achieve a CR, but if they have no donor, then Philadelphia positive ALL is almost a death sentence. If there is a donor, the cure rate was about 40%. At MD Anderson, in 2000, we added imatinib to hyper-CVAD. We replaced it in 2006 with dasatinib, and in 2010 with ponatinib. And because the patients were living longer, they started having CNS relapses, so we increased the intrathecals from 8 to 12. And in 2017, we changed our approach completely to not using chemotherapy anymore and using allogeneic transplantation only rare. One of the questions is, why do we need the second and third generation TKIs? In Europe and in many parts of the United States, people still believe that imatinib is as good as dasatinib. This is a randomized study from China in childhood ALL that showed that in a randomized trial of intensive chemotherapy with either dasatinib or imatinib, dasatinib was superior to imatinib, improving the 4-year survival from 70 to 90%. Now, notice also that, and this is a common theme in childhood versus adult ALL, that children do much better than adults, even when you compare apples to apples. So even with the intensive chemotherapy imatinib, in adult ALL, the 4-year survival would be 40%. In childhood ALL, it's 70%. And it is the same in childhood versus adult ALL, not only for intensive chemotherapy, but also for transplant, for antibodies, for CAR T cells, and for targeted therapies in Philadelphia positive ALL. But this study has shown clearly that the newer, more effective TKIs can improve the outcome in Philadelphia positive ALL. So there are 4 things that convince us to change from the historical hyper-CVAD imatinib to the current. The first one is we started noticing that in many of the patients who were relapsing, the mutations were occurring with the T315I mutation, which was not sensitive to imatinib or dasatinib. So this is what led us to use ponatinib. The second one, as I mentioned, is with the hyper-CVAD ponatinib, patients were living longer, and with the 8 intrathecals, we started seeing CNS relapses in the long run at a rate of about 15% shown in blue. So we increased the intrathecals to 12, and we haven't seen relapses since then. The third is the finding that the newer antibodies, blinatumomab and inotuzumab, in the subset of patients with refractory relapse Philadelphia positive ALL, these antibodies were doing better than standard of care intensive chemotherapy, improving the CR rates and the survival. So we thought if they are better than intensive chemotherapy, then why not replace the intensive chemotherapy with blinatumomab? And this is what led to the current regimen which we're developing, ponatinib blinatumomab. So ponatinib is used not at 45 milligrams, but only at 30 milligrams. Blinatumomab is not added during the remission, but during the induction, and it's given for 5 cycles. And as I mentioned, the intrathecals are 12. So this is an update of the published data recently in Lancet Hematology. We have now treated 60 patients with simultaneous ponatinib, 30 milligrams with a reduction to 15 milligrams in complete molecular remission, blinatumomab 5 courses, 12 intrathecals. So what you see is the CR rate is 97%, the complete molecular response rate and NGS MRD negativity is 90%, and the 2-year survival is up to about 88%. So these are very good results at 3 years. And what you see is only 1 patient went to transplant. We have 4 relapses, 2 in the CNS, 1 with Philadelphia negative disease, and 1 systemic. So for the CNS, we're going to increase the intrathecals to 12 because we believe that because we removed all the high-dose RC, we may see CNS relapses more often than in the past. And what we see with this regimen is that the complete molecular response is achieved very quickly. So these are PCR done on a weekly basis. And what you see is before the beginning of the 2nd cycle of blinatumomab, 75% of the patients have achieved already a complete molecular response. And this slide shows the comparison of ponatinib blinatumomab in red to the hyper-CVAD ponatinib in blue, and also to the hyper-CVAD dasatinib, which is the current standard of care in the United States, followed by allogeneic transplant, where the 5-year survival is only 50%. So we believe that the new regimen is going to be the new standard of care. Now let's move to pre-BALL, and this is where the therapeutic revolution comes with the introduction of the newer antibodies that target CD19, like blinatumomab, CD22, like inotuzumab, but also we're very excited about the new CD20 bispecific T-cell engagers, which have been approved for lymphoma. So we may start using them instead of rituximab. On the right side is the revolution with the CAR T cells, which are certainly major breakthroughs in lymphoma and myeloma. But in ALL, for them to be effective, I believe we should stop using them in salvage. We should start using them in frontline therapy in minimal residual disease. So first, historical data with blinatumomab or inotuzumab as single agents versus intensive chemotherapy in refractory relapse ALL. So those pilot trials led to the randomized trials comparing blinatumomab and inotuzumab to intensive chemotherapy. And they showed that the CR rate was significantly higher, but importantly, the survival was better. But when you look at the survival, there's only a modest improvement, and you're paying a lot of money, about $250,000 for each of those antibodies. So since the FDA approval of these as single agents in refractory relapse ALL, at MD Anderson, we've never used them in this situation. We have always combined them with intensive chemotherapy in both the salvage and the frontline setting. So here's the data in younger patients with ALL, where we have used hyper-CVAD. And initially, so what you see is 3 changes compared to the standard intensive chemotherapy. So we have shortened the hyper-CVAD from 8 courses to 5 courses. So we reduced the chemotherapy by 50%. Then we added blinatumomab in sequence for 4 courses. And then we shortened the maintenance from 2.5 to 3 years to only 1 year with blinatumomab in between. Later on, when inotuzumab was afforded to us as free on the study, we added it, but we added it in fractionated lower doses in 2 of the intensive chemotherapy courses and 2 of the blinatumomab courses. And this is the updated data. So we published it in 2022 in Lancet Hematology in the first 30 patients. Now we have 72 patients. So the treatment is hyper-CVAD for cycles, blinatumomab for cycles, pumped for 1 year, and then the later addition of inotuzumab. But notice the dose is not 1.8 milligrams per meter square per course. It's only 0.6 milligrams per meter square per course. And we do 4 courses, so the maximum is 2.4 milligrams per meter square instead of 5.7 milligrams per meter square, which causes the toxicity. So the CR rate was 100%, MRD negativity 95%, NGS MRD negativity 74%. We have a long-term experience with hyper-CVAD, so the mortality with hyper-CVAD in the community practice is 10%. Our mortality is 0%. On the left side is the overall survival at 3 years in red, which is 88%. That's the first time we see this. In the middle is the cohort where we added inotuzumab in red, so the patients are living better. And on the right side is the comparison to the hyper-CVAD, inoblina, to the immediate past regimen with hyper-CVAD of ofatumumab. So what you see is the 4-year survival is improving because we added 2 antibodies which are not only effective, but also more effective than intensive chemotherapy. So we're hoping that this will continue to be positive. And on this slide, on the left side, I show patients who are Philadelphia-like in blue, so they still do less well, but again, the 3 to 4 year survival is not anymore 25%, it's over 70%. And on the right side is the outcome by transplant. So with this effective regimen, the transplant is used only in the highest risk, such as MLL, AML, and patients with complex karyotype or patients with minimal residual disease in remission. Now, people worry about the inotuzumab veno-occlusive disease, and that's because they use inotuzumab as a single dose of 1.8 milligrams per meter square. And what you see is continued publications where patients are taken to transplant, and the incidence of VOD is 20%. With the regimen that we're using, again, we fractionate the dose. We max the dose at 2.7 milligram per meter square instead of the 5.6 that causes VOD. We do not use concomitant hepatotoxic drugs like asparaginase or erythromycin, and we monitor carefully for early signs of VOD. We use also high-dose solumedrol when we see this, and we distance the last inotuzumab dose from the transplant when needed. So with this, we have seen an incidence of VOD, which is now in the range of 2 to 3% only. So those experiences are being run by others, but mostly using blinatumomab. So the top two are the MD Anderson experience. The bottom three are experiences from Germany, France, and Australia, where they add blinatumomab during the consolidation, and what they see is similar results, very high CR rates, MRD negative rates, and early good survival. This is a study from Holland, where they did something very interesting. They had a pre-phase of 10 days of steroids and 2 weeks of blinatumomab before they started the intensive chemotherapy. And then with the intensive chemotherapy, they added 2 more courses of blinatumomab. What's interesting is with those 14 days of steroids and blinatumomab, they did bone marrows and showed a CR rate in 63% of the patients, which is amazing and shows you how effective blinatumomab is. They are also reporting that the 2-year survival in younger patients is now 82%, which is amazing. But also an interesting finding is of the 71 patients, they discontinued the blinatumomab in 13% due to toxicity. And my view is no patient should have blinatumomab discontinued if you're managing them well. So how do you manage blinatumomab toxicity? You ask the patient to write the same sentence every day. When you see a worsening in the handwriting, tremors, neurologic toxicity, you immediately hold the blinatumomab. You give decadron 8Q8 for 2 days, and then you restart the blina either at the same dose, or you can do those reductions from 28 to 15 or 9 or even 5 micrograms. Also, we use now Keppra routinely, not to prevent seizures, but also to prevent the neurotoxicity. And if you have persistent neurotoxicity, you can give 1 intrathecal with Araci or methotrexate. If you do the CSF studies, you will find that they may report quote-unquote blast, but these are polyclonal T cells which are causing the neurotoxicity, which have been introduced into the CSF by blinatumomab. And when you give the intrathecal chemotherapy, you kill those T cells and you eliminate the neurotoxicity. This is another study that was reported at the last ASH meeting, which is very important. So this is the intergroup in the United States, where they randomize patients after induction of chemotherapy, if they are MRD negative, to 2 cycles of blinatumomab or no blinatumomab, and then more chemotherapy. And they were almost shocked to see several things. So first of all, there were about 500 patients treated, but only half of the patients became MRD negative. So these are the best of the best. These were the patients who were randomized 1-to-1 to blina or intensive chemotherapy. And what they noticed is with the long-term follow-up, the 5-year survival increased from 55% to 80%, which is an amazing difference and shows how important blinatumomab is going to be in the future of ALL therapy. But notice several things. The first one is we know that blinatumomab benefits patients who are MRD positive, but how do they benefit patients who are MRD flow cytometry negative? And that's because among these patients, many are still clonoSEQ MRD positive, and these are the patients that benefit. The second important observation, so now we know that blinatumomab benefits all patients with ALL, not only the ones who are MRD positive, but the ones who are also MRD negative. But also note that this is only half of the patients who are supposed to do the best. And yet with the pediatric inspired regimen, the 5-year survival is not 70%, it's only 55%. So what we wanted to see is how does hyper-CVAD compare to this group of patients? So what we did is take the patients treated with hyper-CVAD before the addition of inotuzumab and blinatumomab. We took them in remission, so flow cytometry MRD in remission, and we noticed that the 5-year survival in our experience is 65%. So that's why we think that the hyper-CVAD, if you know how to manage it and to give the full treatment, may be better, and in our hands, less toxic than the pediatric inspired regimens. Now let's talk about minimal residual disease. So this is a meta-analysis that looked at MRD positivity in first remission in ALL. So let's look first at the top right curve, which is pediatric ALL. And what you see is the patients in blue who are MRD positive have a 10-year survival of about 60% compared to 90% for the others, or maybe 80%. So again, the observation that even the patients who are MRD positive, they do not have a fatal outcome. They have a 10-year survival of 50%. But in adult ALL, which is the bottom curve here, figure D, if they are MRD positive in remission, then the 4-year survival is 20% only. So not 10-year survival of 55%, but a 4-year survival of 20%. So keep this figure in mind. So at MD Anderson, we built on the German experience. The Germans gave 2 courses of blinatumomab in MRD positive remission, and then they sent the patients to transplant. At MD Anderson, we treated 37 patients who were MRD positive, but we gave them 5 cycles before considering transplant. And what we see is a bit of a difference. So the 4-year survival is not 20% as the historical. It's not 45% as in the German experience, but it's 60%, which is, again, incredible. And on the right side, you see transplant versus no transplant. So in blue, because in red, because the patients on transplant can die, there is no benefit of the transplantation. So now what we're doing is 5 cycles of blinatumomab and then the CAR T cells to be able to perhaps improve the survival to 80%, we hope. So I talked about clonoSEQ MRD negativity, and this is to show why we want to do this. So we have taken 74 patients and we measure residual disease by clonoSEQ, so looking at 1 to 3 million cells, versus the traditional flow cytometry. So what we see is that flow cytometry negativity, which is in red, does not protect from relapse. Patients who are flow cytometry MRD negative in first remission still have a relapse rate in the range of 40%. In blue are the patients who are clonoSEQ MRD negative. So usually you do not see relapses and the survival is much better. So that's why we need to shift from the classical flow cytometry MRD measurements to the clonoSEQ MRD measurements. So if you have a patient with clonoSEQ MRD negativity, you know that the patients are going to do very well. If they are clonoSEQ MRD positive, even at 10 cells in a million, we have noticed that those patients will invariably relapse. So you have to do something about this. Now, the older ALL, we have used a similar strategy. So I'm going to show you this briefly. So we used 4 cycles of chemotherapy, but not the intensive chemotherapy. It's the mini CVD, and it's published. At the beginning, we added the inotuzumab in the older ALL because that's what the companies gave us for free. And then we added the blinatumomab. And what we noticed is that with the mini CVD inoblina, we almost doubled the 5-year survival, but still the patients are not doing great. So what we're going to do now is use less chemotherapy, more of the inoblina in the front line, and then use the CAR T cells in these patients. And these are, again, studies from elsewhere. So here in the older ALL, there are studies with both blinatumomab and inotuzumab. So this is the Southwest Oncology study. This is a German study, another German study, so with either blina or ino, and then a French study. And what you see is in all those, the investigators are reporting similar data as at MD Anderson, a very high CR rate, and a 3-year survival of about 50%. So when do we do allogeneic transplantation? Today, we do not do transplant as a blanket treatment in first remission. We reserve it to patients with translocation 11q23, precursor T-cell ALL, complex karyotype with 5 abnormalities or more, and patients who are Philadelphia-like CRLF2 positive, but with a JAK mutation also. So we do not use transplant in MRD positivity. We try to remedy this with blinatumomab or with inotuzumab. The last set of slides are in the salvage setting. So as you know, in adult ALL, patients who relapse have again a death sentence with a 5-year survival of 5 to 7%, even if you send them to transplant. So here I show the data with the mini CVD inotuzumab and later the addition of blinatumomab. We have treated 110 patients. The marrow CR rate is 83%, NGS MRD negativity 82%. Veno-occlusive disease was about 9% before we amended to adding the blinatumomab to using ursodeoxychol as prophylaxis. So post-amendment, the incidence of veno-occlusive disease is only 2%. What you see is the 3-year survival is 40%, so not a death sentence of a survival of 10%. On the right side is since we added the blinatumomab, so the 3-year survival is now about 50%. On this slide is salvage 1, where the 5-year survival is close to 40%. So that's why if you have a patient with ALL relapse, I think the best regimen is the mini CVD inoblina, then followed by CAR T cells if needed. You shouldn't wait and use single agent inotuzumab or single agent blinatumomab. And on the right side, I show that the transplant does not work that well. That's why you need to use the CAR T cells. And this is the comparison to the mini CVD inoblina, to our historical experience with blina, just to say that you should not use those antibodies as single agents in refractory relapsed acute lymphocytic leukemia. So in summary, we have much better treatments today for ALL. In Philadelphia positive ALL, ponatinib or dasatinib if the patients have arterio-occlusive problems. With blinatumomab is a very good effective therapy. We know that the antibodies are very effective. We know that the CAR T cells are very effective, but I think we should not use them as approved by the FDA. We should use them as I've shown you in the previous slides. And I think the future of precursor ALL therapy is going to be with much less chemotherapy for shorter durations, adding blinatumomab, inotuzumab, and perhaps new bispecific T-cell engagers targeting CD20, or even trispecific T-cell engagers. We should use the CAR T cells in sequence in first remission, replacing allogeneic transplantation, and all patients should be monitored by NGS MRD to decide on changes of the treatment and duration of treatment. So if a patient is NGS MRD negative for 6 months, then you know that this patient has a high cure rate. If a patient is an NGS MRD positive, even at 5 cells in a million, those patients are going to relapse, so you have to change the treatment. Thank you for your attention, and thank you for inviting me to this presentation. If you have any questions, please email me or call my cell and we can discuss your patients. Thank you for inviting me, Dr. Zapata.
Thank you, Professor Kantarjian. Let's do our Q&A session. The first question is, what's the role of asparaginase in the treatment of ALL?
So I think asparaginase historically had a very important role in the treatment of ALL. In pediatric studies, they show that in patients who cannot continue asparaginase for different reasons, the cure rate decreases by 20%. So many ALL experts in the United States still believe that asparaginase has a major role, not only in pediatric, but in adult ALL. I happen to think differently. I think that the new antibodies are going to be much more effective than asparaginase and much less toxic, because I keep getting patients on asparaginase who have arterio-occlusive events. The worst one is the sinus thrombosis, which is uncommon, but it is happening. Now, I still think asparaginase has a role in T-cell ALL because we do not have effective antibodies or CAR T cells, but there is data from China with the CD7 CAR T cells, which is very, very impressive. So I'm hoping that even in T-cell ALL in the future, we may be able to minimize the role of asparaginase by adding the venetoclax and by perhaps using some of the CD7 CAR T cells.
Thank you very much, Professor Kantarjian.
Muchas gracias por acompañarnos en nuestro cuarto coloquio de leucemias agudas y síndromes mielodisplásicos. Mi nombre es Nidia Zapata y junto con la doctora Marta Alvarado agradecemos el que nos hayas acompañado.